Hello, everyone. I'm sending you beautiful morning greetings from Egypt. This is my Tolba. It's a great pleasure to be with you today and hosting this session in collaboration with my dear colleagues from the Global Young Academy, Dr. Stephen Kohler and Dr. Shaima Ainani. This session, the New Voices in Global Health, is organized in collaboration between the Global Young Academy and the World Health Summit for the third year. And this year, the session will be discussing COVID-19 vaccination rollout, opportunities and challenges. And it's my pleasure to introduce our esteemed speakers and also my colleagues from the Global Young Academy, Dr. Catherine Crow, Dr. Marily Claessens, Dr. David Rivas, Dr. Suraj Bharati, and Dr. Roshiana Parpor. This session is being recorded, and for your questions, please feel free to post your questions in the chat function, and your questions will be monitored and collected throughout the session. We will have a comprehensive discussion session at the end of our panel. Please join me to welcome our first speaker, Dr. Catherine Crow. She's an expert in cultural and linguistic diversity from the University of Iceland. She will highlight the importance of clear communication of information to combat COVID-19 pandemic.
Thank you. So community participation in vaccination programs relies on information reaching the people who need to know it. People need information on vaccine safety and side effects, about vaccine eligibility, availability, and scheduling. And this process really involves 3 steps. First, people need to access the information. Then they need to be able to understand the information. And finally, they need to be able to use this information to get to a vaccination location and give their informed consent to be vaccinated. But can everyone access, understand, and use the information that you're giving out about vaccine programs? What if, when you try to read a newspaper, written information looks like this? Or what if, when you're listening to the news on the TV, it sounds more like this? What if you want to clarify some information that you've heard, but your communication looks like this? This has been the experience of millions of people with communication disorders through the COVID-19 pandemic. So what is a communication disorder and how does it affect your ability to successfully roll out COVID-19 vaccination programs? Well, a communication disorder is an impairment in the ability to receive, send, process, and or comprehend communication that might be verbal, signed, written, or in a graphic format. And a communication disorder may be evident through the process of hearing, speech, and or language, and it could range from mild to profound, and it could be developmental or something that's acquired. And communication disorders impact 1 in 10 people in the US, with the prevalence being higher in Global South. So communication disorders can be experienced by people with a sensory loss, such as hearing loss, a neurological condition, such as a traumatic brain injury or stroke or dementia. Also people with developmental differences, such as developmental language disorder, neurodiversity, dyslexia, or developmental delays. So currently, health information is communicated by officials who use complex language. Information is often located or facing barriers in accessing, understand, and using the accurate health information that you're providing. In addition, people with communication disorders may also be more susceptible to misinformation. Misinformation about COVID-19 vaccination is usually clearer and more concise than the information that's coming from official sources. People with communication disorders may also have more difficulty in evaluating the truth of information that they receive and may struggle to fact check, making them more vulnerable. So I'm a speech language therapist. What do I know about vaccination rollout? Well, not very much about the vaccine side of things, but I am an expert in communication disorders. Around 10% of the people that you're trying to get information to are people with communication disorders. Scientists, health officials, and politicians are incredibly skilled at conveying complex and detail-oriented information about really important topics, and they've used these communication skills really effectively throughout the pandemic. However, the communication is rarely in plain language or in simple language. Using plain language to convey ideas means communicating as directly and simply as you can with your audience. It means organizing your message, being clear about your purpose, avoiding contradictions and complexities. It means using simple words and using words that are familiar and are frequently used in the vocabulary of the people that you're talking to, and avoiding jargon and idiomatic language. It means using clear sentences. Sentences should be short and with few subordinate clauses. And what I'm describing is the exact opposite of all scientific communication. And I'm not saying that it's easy. It is very, very hard to do. And there are already people in your countries who are experts in communicating using plain language. People like speech language pathologists, your national bodies for speech language pathology, and advocacy groups for people with communication disorders. These people are untapped allies in the public health efforts against COVID-19. Let us work with you to help you reach some of the hard to reach populations, segments of the population, and get them to your vaccination centres. So our message is very simple. Not be communicating about your in simple, plain language, accessible to as many people as possible. Clear communication will combat misinformation, increase the proportion of the population who are willing to be vaccinated, and decrease vaccine hesitancy where the root cause is a lack of access to comprehensible information. So first, governments, vaccination programs, health professionals need to be aware of how complex the language that they are using is, even if they think they're already using simple language. Second, we need to utilize people and resources within each country that can guide how the information is translated into the appropriate context, using language that can be understood by people with communication disorders. And third, once you have this really plain, simple information, it needs to be accessible. The information needs to be in places where it's easy for people with communication difficulties to find, such as rehabilitation service providers. The information has to be in the language that people with communication disorders can access. And this includes signed languages, and yes, there is more than one signed language. And it also includes Indigenous languages. And then you need to make sure that it's in an accessible format as well. Can you get it in Braille? Is it screen reader accessible? How can people actually access your information? When you provide health-related information in plain, simple language, everybody wins. This includes people with communication disorders, but also people with lower education levels, lower literacy levels, and people like me who live in a country where they're not especially fluent in the language that's being used. Thank you.
Thank you so much, Catherine, for your elegant presentation and for highlighting the importance of the integrated work between the scientists and the experts of communication. I'm sure we will have an interesting discussion about that at the end. Now let's welcome together our next speaker, Dr. Marilee Claessens. She's an infectious disease expert and an epidemiologist from the University of Namibia. She will talk about the difficulty of choices in the era of COVID-19 vaccination.
Thank you very much, and thank you very much for this opportunity. So my experience of the COVID-19 pandemic in Namibia has been marked by difficult choices, hence this introductory slide showing Scylla and Charybdis, which refer to one of the experience of Odysseus during his journey, which is written about by Homer. Scylla is the monster with the 6 heads, and Charybdis, the whirlpool. And I assume that this is where the original expression between the devil and the deep blue sea have originated. So how is this applicable to my experience of the COVID pandemic in Namibia, and specifically with regards to vaccination? So first things first, on a philosophical level, we know that we have a choice to vaccinate or not. And as David Hume so elegantly put it, there is no such thing as freedom of choice unless there is freedom to refuse. But what does this mean in a global context and in a Namibian context? And I love the way that this syringe is breaking the virus in two. But for me, it's also a metaphor of how the world is almost broken in two between one group getting vaccinated and the other vehemently disagreeing to be vaccinated. What we cannot escape from is our responsibility, not just towards ourselves, but also to the communities we are from. And this is the underlying philosophical tenet of herd immunity. In Africa, we have a saying, I am because we are, which is the concept of Ubuntu. This, in the context of the vaccine, can only become real if we care not only about ourselves, but about the community and the protection of everyone in the community. So what has happened in Namibia? We have had 3 waves of COVID. The third included and was dominated by the dreaded Delta variant. And at one stage, Namibia had the highest mortality rate in the world in July. At the same time, we had less than 6% of the population fully vaccinated, and we ran out of vaccine. Currently, although we have received vaccines again, and the picture on the right is an indication from the 23rd of October, we have Covishield and Sinopharm, few doses of Johnson & Johnson vaccine and Pfizer, and these are not even included on the graphic from the McGill's Institute in Canada. And our Sputnik vaccine doses have been stopped because of an indication of an association with HIV infection, of which we already have a very high prevalence in Namibia. I was vaccinated very early in the pandemic with Sinopharm, and to be able to attend the World Health Summit in person, I had to be revaccinated with one of the accepted vaccines in Germany, in my case, Johnson & Johnson. We have also seen large proportions of our people being extremely hesitant to take the vaccine. But as mentioned before, between vaccine stockouts and, on the other hand, vaccine nationalism, it was difficult to keep our population motivated to actually access the vaccine. Finally, in Namibia, we have an extremely high incidence of tuberculosis amidst HIV and COVID. In 2020 alone, we have diagnosed only 25% of our estimated drug-resistant TB cases. And we know some of them are already extensively drug-resistant to the latest drugs, bedaquiline and linezolid. We are therefore working on a study to look specifically at the interaction between COVID, HIV, and TB to strengthen our case finding and our health systems so that we address these missing TB cases. So I want to close with this picture on the right-hand side, showing the face of a very scared TB patient when looking at her chest X-ray with lungs full of cavities. This is on ground level what the choices we make must prevent and must address, so that we have amongst the poorest and the most marginalized, not fear, but understanding and hope. Thank you.
Thank you so much, Dr. Marili, for the enlightening presentation. And now we have heard about 2 important aspects, the communication problem and the problem of not having an actual choice in the process of vaccination. So let's go now to the step of hearing more about the implementation strategies from our next speakers. Let's welcome our third speaker, Dr. Suraj Batari. He's a public health specialist and a physician from Nepal. And he will talk, his talk will cover various aspects of COVID-19 vaccination programs in South Asia and Nepal. Welcome, Dr. Suraj.
Thank you, Mai. So just curious, would you share the slides or should I share my screen?
No, it's not displayed yet.
Okay, sorry. So the topic of my presentation would be the unmet commitments of COVID-19 vaccine coverage in Southeast Asia. I hope my slides are visible. Mai, can you confirm?
Yeah, it's visible now.
Okay. So so far, globally, less than 50% of the people have received at least one dose. 6.76 billion doses has been administered in total, and then 22 million doses of COVID vaccine have been administered each day. You can see from this chart that the COVID vaccination coverage is really high in the few high-income countries, whereas the developing countries, for example, in Southeast Asia, like India, Thailand, Indonesia, Bangladesh, these have a quite low coverage, below 50%. In terms of this COVID vaccine coverage, so you can see that vaccination coverage is not equal everywhere, and this has been a debate recently among the global experts and then also even the global public. In total, the low-income country coverage of COVID-19 vaccine, it stands at 2.9% for one dose, and then even less, 1.3% for full dose. So let me speak about the vaccine coverage in the Southeast Asia region. You can see that two countries, Bhutan and Maldives, have done relatively better in terms of vaccine coverage. They have vaccinated almost 65% of the total population, whereas the lowest coverage is in Myanmar, only 7.1% of the total population, and then also in India and Indonesia. Also in Timor-Leste. So, but in terms of the number of vaccine doses being administered to the public, I think India stands at the top. They have almost, they have crossed 1 billion of the target doses administered to the public. So this is a proud moment for India, but because of the high number of population, people living in India, probably the coverage, the full coverage may take some time. So I think the vaccine manufacturers as well as the vaccine governments should really speed up their activities to cover the population. When we talk about Nepal, Nepal is a small low-income country in Southeast Asia, and nationally, out of 30 million population, the first dose has been received by around 28 to 30% of population. The full dose has been received by around 22% as of today. However, if we look at the target population of more than 18 years, the coverage is around 43% for one dose, and the full dose coverage is 32.6%. So when being a citizen of Nepal, I found this campaign quite successful because of the several things that I mentioned here. Actually, Nepal was one of the first countries in South Asia after India to deploy the national vaccination, started vaccination on 27th of this year with the Covishield vaccine developed in India, but designed or let's say produced in the UK, the AstraZeneca. So a few of the successful insights that we can take from Nepal's vaccine deployment program are strong political will, and the kind of vaccine diplomacy in the Southeast Asia region. The ministers, the governments, they really prioritize this task. So they had a strong will, and they had a strong desire to vaccinate people. So and they also amended the health regulations that are required for the registration of new vaccines. This also opened door for very new vaccines, although they were not even approved by the WHO at some point of time. They opened doors for the vaccines for emergency use as well. Likewise, the priorities were set out to ensure the equity. For example, healthcare workers were the first one to receive the vaccine doses. Likewise, the immunization program in Nepal is considered one of the successful programs. Almost over 90% of the coverage of the childhood immunization program. So this was quite useful in deploying the COVID vaccine. So the effective vaccine delivery system is another point that led to a successful deployment. Likewise, the rapid procurement process and the phase-wise expansion of vaccine coverage. When we talk about the vaccine research and development, you can see in the chart above that there are several vaccines under development, and currently 21 vaccines are in use. For example, there are 2 vaccines, Moderna and Johnson & Johnson, being produced in USA. Then in the UK, the AstraZeneca vaccines, and the Pfizer-BioNTech in Germany. There are 7 vaccines under use, which are produced in China, and other countries like Russia, India, Cuba, Kazakhstan, Iran, and Taiwan. Taiwan have also developed the vaccines that are currently in use in different countries. So this kind of rapid development in vaccine research and deployment is one of the, I think, successful program in the global public health, I think. However, there comes a challenge now to many countries, that the commitments made by the high-income countries, the low-income nations regarding the vaccine donation, or let's say not only donation, but even the low-income countries, they want to purchase the vaccine. The vaccine developers are not able to deliver the doses they have committed. So this has been a challenge, and this has been really affecting the vaccine equity globally. For example, the commitment made by the wealthy nations to low-income countries of 1.8 billion doses. Out of them, only I think 16% have arrived. As per the data we see on the internet, actually from the website of UNICEF, Gavi, the People Vaccines Alliance, and several other sources. So this is quite low, and this puts us away from getting over of this pandemic. I think, for example, the USA has placed the doses of 1.1 billion, and so far, I think 200 million has been delivered to the low-income nations. Likewise, the Team Europe, they have placed 450 million, but out of them, I think around 8% has been delivered. And the percentages are similar, I think below 10% from UK and Canada. And when we talk about COVAX, out of 1.2 billion doses placed, nearly 1/3 had been delivered, and hopefully the full doses will be delivered very soon, and this will help us get away from this pandemic. For example, but there has been another issue, and it's on debate, that booster shots have been administered in many countries, many wealthy countries where they can afford higher number of doses, and there has been a debate that this will divert supply from the urgent area of need. So this has to be considered, and then I think the developing countries need to raise their voice, and the organizations like WHO and Gavi, and they need to speak up as well for the equitable distribution of the doses. And now even the FDA, the US, they authorize the use of the mixing sorts of boosters, and probably this will also affect the equitable distributions, because many countries, they want to administer their population booster dose, and then regardless of the type of vaccine, so they can use whatever vaccine they want to use for as a boosters if this is approved in other countries as well. So this will also affect the global vaccine delivery mechanism. And now another new challenge is that in some high countries, because of the lower utilization rate, maybe some vaccines could expire soon. So this is also another challenge, and this is affecting the vaccine equity in the world. So here in this slide, I would like to list out few challenges or barriers of universal vaccine coverage. For example, the countries that are developing these vaccines are not quite flexible in sharing the patent, or let's say intellectual property rights. At the same time, the technology transfer is another issue, and from the lower income, or let's say developing countries perspective, they may not be quite ready to accept the technology because of the lack of resources or lack of commitment. So this is another challenge. Likewise, the vaccine misinformation, as well as the hesitancy, this has affected the coverage in several countries, and this has to be addressed as well. The supply chain issues is another challenge, mostly in the difficult terrain countries like Nepal. You can see in the picture that the vaccine has to be transported to the hills and mountains, and where there is no better roads. So this may affect the cold chain mechanism, or let's say the delivery systems, because of the different natural disasters like landslides, flooding, and then that may affect the vaccine deployment in the remote areas, and this may impact the universal coverage at national level. So is the production cost, not only production but also the packaging, and then kind of delivery and also deployment cost involved may also impact the vaccine coverage. Likewise, the vaccination of children is now being initiated in many, only a few countries like in the US or UK, and they are increasing the vaccination of above 12 years, or even less than 12, like 5 to 12 years of children. But this is a very far cry for poor countries, because even the needy ones, like the elderly, the adults, the frontliners, they are not receiving the vaccine doses. We recently read a report of the WHO that many healthcare workers died of COVID-19 vaccinations worldwide, even more so in the low-income countries, maybe because of the lower vaccination rate. So probably the children might be left behind for quite a longer time if we want to vaccinate the whole nation. Probably they would be the last to get benefit. So these are huge barriers, but there are several other challenges at the regional, in the global, and also with local context. Also, several barriers to universal vaccine coverage. So this topic is quite open for discussion. Thank you for listening to me, and then I'll be happy to take questions, and then we can discuss. Thank you.
Thank you so much, Dr. Suraj. And it was really impressive to emphasize the gap in the vaccination equality. And now we move to think about if we have the correct way of communicating the information to the public about the vaccinations, and we provided the vaccines and we made it accessible. There is one more classical barrier to vaccination, which is the fear of needles. So our next speaker, Professor David Rivas, he's an expert in microfluidics and transdermal drug delivery alternatives. He will give us an overview of an innovative method for vaccination without a needle. So welcome, Professor David.
Yeah, thank you, Mai, for the nice introduction. Can you hear me?
Yeah.
Yes, and the slides are visible?
Not yet.
Not yet? Okay, let's see. There's something missing here. Yes. Right, can you see them now? Yes. All right, well, maybe I have to move this one. Yes, switch the view.
Yeah, like the previous step.
But this is the right screen, right?
You have to swap this place.
Again, it's weird. Okay, let's try this now. And now you have the right one?
Yeah.
Yes,
Yeah,
okay.
perfect.
All right, so well, my screen is on the left side, but I'll try to look at the camera so that the people who are watching can have a closer, real experience to that presentation. So I want to talk about something that is a bit of a pity, that after all the effort that governments and pharmaceutical companies and doctors and scientists all over the world have put into trying to vaccinate as soon as possible as many people, we have to deal with a very old story, which is the fear of needles. So what I would try to do in the following few slides is to tell you a bit more of a way that I believe, and my team that supports me think we could have better uptake of the vaccination that is ongoing and also being prepared for the next pandemics. So the first thing I want to show you is a little video on how, in principle, we could be injecting without needle. So you see a laser is hitting a liquid that pushes at velocities high enough to penetrate the skin. And what I'm showing you on the right is an actual experimental setup of the technology we are developing right now. And I will tell you a bit more in a minute. But basically, we believe that if we could inject without needles, then we could have many advantages, and I will try to summarize the most important in my view, and later on, well, we can have more questions and answers. So in the media in the last few months, there's new statistics about how large this problem of phobia or fear of needles is, because in the past, some of the numbers that we can really get from reliable sources tend to underestimate how big the fear to a sharp object is. And of course, fear is a more complex problem that I cannot really address with the technology we are developing. But if we could at least reduce in a considerable percentage number the amount of people who are afraid of the sharp object that typically is used for vaccinations, then I think it would be better for the world and for everybody in general. Of course, there's one of these examples that I cannot really solve with the technologies, the trust in institutions or what sits in the vaccine. But if we develop a platform technology that can be used to inject different type of drugs, not only for COVID, for TB or other medical applications, then I think that we can make a good progress. Well, this in more lay terms, 1 in 5 persons, at least in the Netherlands and UK, is afraid of needles. And of course, this number could be a bit higher. But there's a less known problem, and has to do with what happens before and after we inject in the traditional way. So whenever we use a needle, it has to be sterilized prior to injection. But after you use these injection materials, like all the syringes and plastic packaging that protects the tools needed to inject, we generate a lot of waste. And sometimes this waste is not properly handled. So we are creating a quite big environmental problem. Already before the ongoing mass vaccinations, it was big enough, but now, of course, it's becoming more visible, and people are starting to pay attention to the amount of waste that we are creating. There's also another interesting advantage if we could inject with the technology I'm proposing, that when you inject with a conventional needle, typically deep into the muscle, it has been very effective in the past, but it has been demonstrated in past studies and ongoing clinical trials that when you inject in the dermis, you might use less volume than the traditional vaccination volumes, which means that all of a sudden you could be injecting more people with the same amount of vaccine that we are able to produce. Now, from a clinical point of view, that also has an advantage that the way we're trying to inject avoids creating a wound in the skin. So any risk of infection after vaccination can be minimized. An even less known problem, but very crucial in the ongoing vaccination campaigns, is that not only the lack of contamination if we reduce the amount of needles used, but the amount of accidents that the health personnel has sometimes by pricking their finger by mistake, this is a big problem, I believe, because if you already have a well-trained nurse or doctor on the field injecting the best vaccines we can create after such a big international operation, and this person needs to receive special treatment or to make some studies to see if no transmission of disease has occurred after this accidental prick incident, then yeah, somebody has to take that position. So I believe that we can also mitigate some of these problems. Now, where we are at this point, and what I wanted to share with you is that from the Global UN Academy, we're trying to also encourage scientists to be a bit more entrepreneurial and taking a bit stronger stance on how can we make some of the technology or the science that we are developing in our laboratories and our universities and bring them a bit faster to society. In this case, I'm trying to illustrate here a prototype that we're trying to bring as soon as possible to the market with technology readiness level 4 approximately. And typically the main problem that scientists face is the gap between the message that politicians or big companies provide and what we can actually achieve with our limited resources in universities. And even developed countries have problems to take it from this TRL 3 to 5 or 6, where the big players can actually make a global impact. And here I would like to finish my presentation, and thank you for listening.
Thank you so much, Professor David, for your interesting idea and for sharing that with everyone. And congratulations for your project. So our final part, so let's talk about a very important fact. Dedicating research efforts and resources to fight COVID-19 pandemic shouldn't make us forget about other existing disease that is already of equal public health burden. So our next speaker, Dr. Luciana Palpa, she's an expert in infectious diseases from Argentina. She will make sure that we should restart the movement against tuberculosis. Welcome, Dr. Luciana.
Okay, thank you. Thank you for the kind introduction. So, can you see my screen? Okay. Well, thank you again. I feel very honored to be here sharing this session with you. So as it has been said, I'm from Argentina, and it really looks like a very remote place at the end of the world, doesn't it? And especially far from those countries in which the first cases of COVID-19 were notified. But it was just a matter of time to have the virus among us. The same will happen with the vaccination. The global positive impact of COVID-19 vaccination will continue as long as the equity in vaccine access and distribution widens. In fact, individual societies are realizing the importance of collective global protection in order to protect themselves. No one is safe from the virus until everyone is safe. The same scientific reasoning behind the need to vaccinate against the SARS-CoV-2 virus worldwide applies to other airborne diseases such as tuberculosis. Tuberculosis is far from a disease of the past. Prior to the COVID-19 pandemic, tuberculosis was the worst leading cause of death from a single infection disease. So let's compare these two diseases. While the COVID-19 disease could be represented as a 2-year-old child, TB is a very old disease. While so far we have multiple COVID vaccines that have been developed in less than 1 year, there is only one approved for TB that has been developed 100 years ago. This lies in stark contrast to over 100 vaccines for COVID-19, which have entered clinical trials, and at least 23 of them which have been authorized for emergency use. The only licensed TB vaccine, the BCG, is available for newborns and infants in TB endemic countries, but its efficacy in adults is really, really low. Like COVID-19, tuberculosis is a global threat and a public health concern of similar scale. While the number of people who died from COVID-19 last year is really shocking, TB has been killing about the same number of people annually for many decades now. Despite the huge global burden of disease, there is little interest and incentive to develop new TB vaccines, as TB is a disease of the poor. So the COVID-19 pandemic has demonstrated that when there is political will and capital, there are extraordinary scientific accomplishments. But what happened then with TB? Why is not the same interest in addressing TB despite remaining a leading cause of death? Well, additionally, COVID-19 has created further challenges for TB control, driven by the restricted access to medical services, the reassignment of healthcare personnel and equipment, and the increase of the exposure of living with TB in poor households during quarantine. All this will translate into increases in TB deaths and cases. In fact, the COVID-19 pandemic is predicted to increase the number of the cases of TB death globally by 20% over the next 5 years. And it's also very sad to confirm that tuberculosis deaths in 2020 have increased for the first time in over a decade. Furthermore, COVID patients co-infected with TB have a higher mortality, highlighting the danger of liaison between both diseases. Again, it highlights the fact that we need to redouble efforts and ensure adequate funding for TB vaccine research. Even during this complex public health situation, many opportunities may emerge from the COVID vaccination rollout for future TB vaccination programs, such as the putative reconfigurations of new vaccines approaches, such as the COVID mRNA based vaccines, which have not been used for TB so far, ensuring public health impact, as well as management of intellectual property, promoting timely and open access to data, as well as increased collaboration and early communication of results, increasing political commitment and multisectoral action, and harnessing the new COVID vaccine delivery platforms with expanding manufacturing capabilities and coordinated trial networks. So I think that all these could be harnessed to accelerate TB vaccine development, testing, and licensure. A rapid rollout of new TB vaccines will require political commitment, funding, mobilization of resources, and multisectoral collaboration. And the decision should not be to invest in COVID versus TB, quite the opposite. Unlike past mistakes which allow the TB and HIV pandemic to overlap, our current gains in social awareness and political engagement should be sustained to avoid TB and COVID-19 co-epidemic. So therefore, we have now an extraordinary opportunity to seize the moment after having experienced at the individual level the detrimental humanitarian impact of the COVID-19 disease, and commit political will and capital to invest in other infectious diseases such as tuberculosis. Even during this 5-minute talk, over 15 people lost their lives due to tuberculosis worldwide. It is time to start paying keen attention to tuberculosis vaccine development, and the clock is ticking. Thank you very much for your attention.
Thank you very much, Dr. Luciana. And it was really very impressive and shocking at the same time. And I hope that your talk today will reach out and will move the things to the right direction. So now we finished. I would like to thank all our esteemed speakers today for sharing your expertise and your thoughts with everyone today. And now it's a time to open the moderated discussion session, which will be moderated by my dear colleagues, Dr. Stephen Kohler and Dr. Shaima Inani. So the floor is yours now. You are free to start.
Thank you. Thank you for every speaker for this nice presentation. It was really interesting, and we have a lot of values and information from your presentation. Now we have some questions. Let's start with Luciana. The first question, why do you think that there is not the same interest in addressing the TB problem despite remaining leading infectious cause of death globally over so many decades?
Okay, thank you. Thank you for the question. So, as you have said, despite being one of the leading cause of death, TB remains as an orphan disease, never a political priority and never up on funding agendas. And this is quite weird because TB is everywhere and can affect everyone. But it is true that there is a group of high burden countries where the risk of getting TB are much higher. These countries are mainly low to middle income countries, which may somehow explain, but of course not justify, why there is so little commercial incentive in new drugs for TB and vaccines for TB. I am pretty sure that TB history would have been different if it would have mainly affected high-income countries. I'm very sorry to say. But anyway, even from the eyes of high-income countries, TB is still a global threat since new multi-drug resistant strains can be developed if transmission is not reduced. In that sense, the emergence of drug resistance poses a present challenge in the context of TB, but worldwide. So therefore, I insist that we urgently need greater political commitment to end this problem.
Okay, thank you. Thank you, Luciana. Now, the next question will be for David. David, can needle-free systems be economically affordable to any country?
Well, definitely with the right construction, yes, because when you create a new technology, having in mind this sort of urgent aspects, at least in our case, our ambition is to make it somehow two-pronged approach. Like in more rich countries, of course, the pricing would be different than when it's deployed to vaccinate or to be delivered in less developed countries. But since it's a new technology, we have the chance to make a life cycle analysis and develop the product in a way that it should be affordable for everybody, at least when it's meant for this sort of global vaccination.
Okay, I see. Thank you. For Suraj, there is another question. What is the public knowledge and perception regarding COVID-19 infection and vaccine against it?
Thank you very much for the question. In April 2021, we conducted a survey in Nepal, and then we found that more than 60% of the people, they had adequate knowledge, or let's say good attitude towards the COVID-19 vaccine. But now it seems that the knowledge and the trust has really increased with the high demand of vaccines. Even people queuing up in the streets or in the vaccination centers to be able to avail them of one of the doses. So there has been a huge hue and cry to get the vaccine dose. So the vaccine knowledge as well as acceptance has been increased recently, especially in the countries like Nepal. But I'm quite sure that there has been some hesitancy and vaccine side in some countries in Europe or even the US, so that the government has to come forward with some some motivation, or let's say prize, or let's say some kind of incentive to encourage people to get vaccinated. And however, we found that in the study we conducted in April this year, half of the people were not aware of the contraindications of the vaccines, for example, a pregnancy, or let's say the chronic disease. I mean, data is not so clear, evidence is not there, but still they were not aware of even simple contraindications like allergy to the vaccines. And also the side effects of the vaccines, because sometimes we heard in the news that some people died of immediately after getting vaccinated, but they were not quite aware of the side effects. This might not be due to the vaccines, might be due to other reasons, maybe due to traffic accidents or other like kind of delirium or those kind of things. So even with the use of alcohol, withdrawal, those kind of things, but people maybe were blaming the vaccine. So we found that 50% of the participants of the survey were not aware of these contraindications, or let's say the side effects and of the vaccine. Likewise, when we interviewed, when we surveyed the pregnant, the people, they were also not aware that the pregnant and lactating mothers were actually were safe to get a vaccine. So about 65% had a false belief that the pregnant women or the lactating women should not take the vaccine. So this kind of findings we got in April, but now maybe I can say that the things have changed due to the use of communication, social media, and then wide communication tools. So and I think this has to be. This kind of survey has to be done again to understand actually what's the knowledge of the new vaccines being coming in the country. For example, every now and then the country is quite interested to get new vaccine, mix of the vaccines, because of not getting the dose or the type of vaccine they want to purchase because of lack of shortage in the global market. So we need to really do this kind of surveys to understand the people's perspective. Over to you, Annie. Thank you.
Thank you, Suraj, for clarification. Actually, the next one will be for Marelli. It was a very interesting topic about the situation in Africa. For myself, I already worked about the COVID-19 in Africa with many African scientists. I know that Africa has many challenges, and the vaccination situation is very bad in Africa. So my question to Marelli, what do you expect about the timeline of vaccine rollout in Namibia and the impact on the epidemic?
Thanks. It's a good question. At the moment, we have actually more than enough stock of vaccine in country. The latest figures that I have heard of is that we have about 800,000 dosages, which, if they are all in arms, will make a huge difference to the proportion of people being vaccinated in Namibia. But the issue is, as I've mentioned in my presentation as well, is not just about having the vaccine in country. It's also about motivating the communities to be vaccinated. And I think on that level, we still have a lot of work to do. I know personally and anecdotally, but also from studies being done at the moment, that very large proportions of people are not interested in getting vaccinated at all. And I think that's something that we have to address very urgently, because at the moment, the concept of herd immunity is very, very far beyond our reach.
So what do you think about the barriers to vaccine acceptance? What is the problem for accepting the vaccine in your country?
I think it's very complex, like it is everywhere in the world. I think misinformation and disinformation plays a huge role, number one, but I think there are also cultural aspects which plays a role. And I think in our context, in the Namibian context, in the Southern African context, and it might be in the African context as such, previous history has shown that people are quite hesitant because of previous experience with being seen as guinea pigs in research. And therefore, the rollout of a new vaccine or a new technology is sometimes met with a lot of skepticism and a lot of hesitancy, because there's also not a lot of trust in science as such. And I think these things are very deep and very complex and should be addressed on multiple layers and multiple levels.
Okay, thanks, Marilee. The next question is directed to Catherine. Actually, it's about why most of the family members just they don't tell people with communications disorders what to do when it comes to COVID-19 precautions and vaccination.
I think it's really complex, but there's quite a few issues. Like as all of us as cognitive, well-thinking adults, we don't always do what our parents tell us to do. So that is a problem. I think people need agency and they need to understand what they're doing and why they're doing it. And so if their friends are telling them that, you know, you're going to die or be infected with, you know, microchips if you take the vaccine, being dragged as an adult to a vaccination center by your parents is not really going to be effective. And that's also assuming, so recently a friend of mine had to attend a funeral of a friend that had a significant communication disorder. She had cerebral palsy, but it was her parents that stopped her getting the vaccine because she wasn't able to get there herself and her parents were against vaccination. And well, one of her parents and her ended up dying from COVID. So it's really complex.
So what do you think, how does intersectionally related to this problem?
I think intersectionality is quite a lot of it. And I have to say, I'm coming from a very privileged position, like from an extremely rich country with a very small population. But the people with communication, people with communication disorders with unmet needs, so they haven't received intervention, haven't received help, are most likely to be linguistically diverse, they're most likely to be poor, they're most likely to have other health conditions related to being poor and related to not being able to access mainstream health care. So I think intersectionality is highly involved. And like Malia was saying, like if you're in a community that has traditionally not had high trust in the government, because you know the government says that you're not allowed to be, people with disabilities are often in that category of being systemically discriminated against, and then the government wants to give you something, it would be met with suspicion.
Okay, thank you. Again to David. We want to know how does your new idea works, or its differences when compared to other needle-free injectors which is available in the market?
Yes, well, thanks for this question, because I think it's also important to clarify. Many people are familiar with mass vaccinations already in the 50s and 60s and 70s using jet injectors without a needle. The main difference from what we're trying to do now is that instead of trying to inject large volumes in one spot in the body of the patient, which has some limitations, we're trying to overcome, for example, bruising. Like when you're trying to inject large volumes in one spot, you can have a painful bleb. But one of the biggest reasons why it was discontinued was that at some point, due to wrong settings of the energy or due to the variability in the skin properties, sometimes the whole liquid will not go through into the body of the person receiving the injection. And then you will have splashback of the liquid, not only on the injector itself, which then not always was sterilized before the next injection, but sometimes you could have biological material in the face of the person who provided the injection. So what we're trying to do is to solve two main problems. One is injecting approximately a fifth of the traditional dose for vaccinations over a larger area on the skin. And this has been proven to provide better immunization. And the second is to minimize all the pain and all the splashback and all the risk of this sort of wrong settings during the injection. So that in a nutshell is the main difference.
Okay, thank you. And again, back to Luciana. Are there other simpler measures besides vaccine development and vaccination, like educational or behavioral changes?
Well, I think that, yes, of course, it's a matter of raising awareness, because the situation is already there, but it's lack of interest at the end of the day what we are seeing. So it's definitely important to raise our voices and to raise awareness on the global impact of this situation for the health globally. So I also think that it's not only the vaccine, also we also need better drugs. So we really need to improve our commitment if we are really decided to end tuberculosis. But for sure, as you might know, being infected with mycobacterium tuberculosis is not only having the disease, it's also experiencing kind of certain, let's say, discrimination. So there is a stigma of people who have the disease. So we also have to work to end this kind of reasoning, because as we all have understood that being infected with SARS-CoV-2 is something that can happen to all of us, and it's not something that makes you a dirty person or something like this. So we also need to understand the same for other infection diseases, which are somehow associated with poverty, and in this regard are also associated with negative, let's say, feeling towards the person who has the disease. So yes, there is a lot that we need to also do in terms of social and communication skills.
Okay, perfect. Again, back to Siraj. We already know the situation in developing countries is very worse after the COVID-19 pandemic. So we would like to know, can the lagging countries learn something from the developed or the more advanced countries in the region, like usage of the mask? Because the vaccination, although it's an important part, but it is not the only part. So what do you think?
Yeah, thank you, Sima, for the question. I agree, vaccination is not the only sort that can help reduce the infection rate. Definitely the public health measures like wearing masks, social distancing, sanitizing often, and then washing hands, even restrictions to the travel, or let's say the public transport. Those kind of things are required. And I think this has really worked in countries like mine. For example, immediately after lockdown, the cases seem to be decreasing whenever there is a wave, the big wave. And also people, when they start wearing masks and then reducing their engagement interactions, then the case seem to be decreased. But whenever they go out, for example, during festivals, we had recent 2 large festivals in the country in the first 2 weeks, from the first weeks of October. And then we saw recent slight increase in the cases. So the public mobility, the events, festivals, those kind of things are really increasing the case. And I think another important, public health measure that the government could take is to encourage the digital mode for the education, like delaying in the reopening of the schools if they are not sure that the children can be protected in the school. Unlike in some developed countries in the US, where there are strict measures for the children and also for the schools, but maybe in the low-income or developing countries, this may not be the scenario. So this has also been a good practice in countries like Nepal, where the online education system has also reduced the transmission among the young and the older, let's say, children. And yes, I agree. So maybe other colleagues have other opinions. Over to you, Sima. Thank you.
So what do you think about the social awareness in your country?
Yeah, the social awareness is really increasing with the wide use of social media like Facebook and Twitter, or let's say even Instagram and TikTok. Even they use a lot of these kind of videos and posts to share the information. So I think it's really making an impact, I think, but there are misinformation, but the good information is also flowing out.
So that's good news. Thank you, Suraj. For Marelli, to what extent can politicians help or hamper the ongoing health improvement efforts?
That's a good question. So I think politicians can help a lot. So I can just refer back to Namibia again, where I know, for instance, our president and first lady have been vaccinated and quite publicly about it. And I think that's something that can probably filter through to many of the rural and marginalized communities as well. When you speak to community leaders and other traditional leaders and engage with them to be vaccinated, I think that can play a huge role in convincing other community members to also be vaccinated. But on the opposite side of the coin, it also can hamper the vaccination efforts if community leaders or church leaders or any other traditional leaders or politicians decide not to be vaccinated and be very vocal about it. And that does happen as well. So I think also in this sphere, we have lots of hard work to do because we need to ensure that our leaders are all on the same side and that they convey the same message and that there's a clear message that is understandable to the man in the street. I think it is detrimental to our vaccination efforts if some leaders have one message and other leaders have exactly the opposite message. And I think for all of us on this panel, the main message should be get vaccinated. And it's an easy message to convey. And that's what all our leaders should focus on as well.
I see. So what about the regulations? What I mean that, for example, here in Egypt, before the starting of the educational year, they put some regulation that all students at all levels should be vaccinated, and any student who will not receive the vaccine will not allow it to enter the university. So is there any such obligations or political regulation from your government about this issue?
We are seeing it more and more in Namibia and across the world. I think it's a very difficult thing. And I think this whole pandemic has forced us to think about personal freedom and community responsibility in many different ways. I find it difficult to force people to get vaccinated because I'm a very strong believer in personal freedom and in personal choice. But I do think it's a balance between what we do as a person and what we do for our communities. And especially in the sense where we work in medical schools or in faculties where we deal with sick people every day, we have to think about their personal safety as well. So for instance, if we say for a medical school student, you have to be vaccinated, it's not just because of the medical student's own safety. It's also because if we think in our context, in the Namibian context, that this medical student might be in contact with someone with TB or with HIV. And that complicates matters enormously if you have TB and HIV and you get COVID on top of that. So I think difficult question, but I do agree in a sense that we have to try to get as much people vaccinated as possible.
Okay, I see. Thanks, Marelli. Again to Catherine. How can we address a fragmented world that is used to consume news and information from so many non-trustable and varied sources?
I feel like that's really outside my scope of expertise. As I'm just a speech language therapist working with people with communication disorders, and that is a problem that the world seems to be unable to solve at the moment. And I'm sorry, I just don't have a solution for that one.
Okay.
I mean, I can talk about our experience in Iceland, which again is extremely privileged, but I come from a very small isolated island, very far away from anyone else. But we have incredibly high trust in our government and public officials. And then the response team in charge of the pandemic, there was 98% public trust in. And I think that partly just made everything smooth, because what they said was what people did. So I think the fragmented information, it was obviously coming from lots of different places, but because we did have a unified team with a unified message, and we have an incredibly small population, that made everything quite a bit less challenging for us.
Okay, thank you, Catherine. We still have some questions, but I would like to ask Stephen if you would like to engage.
Yeah, thank you, Shaima. I'd be happy to continue with some further questions, and maybe I would also like to invite our speakers and panelists to raise their hands to also ask direct questions or point out maybe linkages between your talks. So I think I continue with questions, but please indicate to me whenever anybody else can or would like to add. Maybe following up, Catherine, with also what you said, where your area of expertise is, what role or what non-verbal, to which extent plays non-verbal communication a role in what you do? And I can think of two things, right? There might be non-verbal communication as a tool to communicate with people with speech disorders, like say using sign language for deaf people, but also I'm not sure if something like body language might be also in the sphere that is interacting with your work.
Yeah, not quite my specialty, but in terms of body language, I think we can all see when public officials or influencers are not genuinely believing in the message that they're giving. So definitely body language has a role in that. In terms of sign languages, that is my specialty. It's incredibly complex, because like spoken languages, we have 300 sign languages in the world. So it's getting information out in the appropriate languages in the appropriate way. It's really difficult. But beyond that, we have, like, the WHO is doing some really great work with graphic. So it's nonverbal in the terms that it's graphic, using comics and means of communication that are not so verbal, which is another really great nonverbal strategy for conveying information. It can obviously not be as complex as the things that we're saying, but it's helpful and much more accessible.
Thank you. And so, short follow-up, are there any technical solutions which can help, like translating written text into sign language at that stage?
No, not really. You need to work with your organizations and your communities. It's the same as, like, it's just, and sign languages are just another kind of languages. So it's the same as if you're dealing with indigenous languages that don't have written forms. You need to find the people who have the knowledge and have the standing in the community to get that information out.
Thank you. Okay, and then I would follow up with Madeleine. Madeleine, you mentioned by now there is like a solid stock of vaccines available in Namibia. And you said it would be great if this gets into people's arms. Can you sort of elaborate maybe a bit further where Namibia as a country stands and what the next steps are in this process?
Thanks, Stefan. So at the moment where we are is we've around 10% of people being fully vaccinated. So taking into account that Namibia is quite a small country in terms of population, so we have 2.5 million people in total in the whole of the country. 800,000 dosages can make a huge difference to the percentage of people being vaccinated. Especially, I'm not sure what the breakdown is of these 800,000, how much of it is Johnson & Johnson, because it's a single dose vaccine, and that would obviously then mean that more people could be vaccinated if all of these were from Johnson & Johnson, but it's not. But I'm not sure what the breakdown is between the different vaccines that we have at the moment. So there are many different places and many different facilities where people could get vaccinated. And I can just speak from experience at the University of Namibia. We've also had a few vaccination drives in encouraging people to come whenever they have time to come and be vaccinated. It's not just for employees from the University of Namibia, it's for anyone in the country or anyone in the city at least. And there's been lots of these kinds of drives from different organizations, public and private, throughout the country, and lots of messages going out through social media networks, and even from the office of the First Lady, talking about the vaccine, talking about the safety profile, talking about the efficacy, and trying to do this in many of the different languages that we have in Namibia, because we've got more than 10 different languages in Namibia. And so it's also for us really important to get the message across in the language that the people speaks. So I think, just to come back to your question, I think there are lots of things that are happening at the moment. I think for me, the biggest thing still is to make sure that people understand it is safe, and that the more people get vaccinated, the better the community is protected.
Thank you, Marilee. And I would like maybe to also bring in Siraj at that stage with a related question. Siraj, I think you really made clear to me also like the diversity of vaccines that are available in some countries, and you included cases of emergency admission through which Nepal made more vaccines available. How open is the population to these different vaccinations which are there? And maybe related to that, how informed is the population about different vaccines?
Yeah, thank you, Stefan, for the question. So far, the government of Nepal has not given a choice for people to choose the vaccine. So whatever vaccine is available in a lot basis, they assign the priority groups in that particular lot, or let's say particular bucket, and then they invite the eligible people to get vaccinated. So people actually do not have the choice. For example, I took the China-made varicella vaccine, Sinopharm vaccine, but now we have there is discussion that Pfizer has arrived just yesterday. But I don't have a choice to take that vaccine. So, for example, this vaccine is for the elderly people with chronic disease, or maybe for the children below 18 years of age. So they have already defined like who will take which vaccine. So, and I heard from some colleagues that some countries are not accepting some kind of vaccines, and they are. This kind of conditions are preventing them from traveling to some countries. For example, I don't want to take the name, but maybe some China-made vaccines are not accepted in Europe or some countries, so they are not able to going to attend their conference. I think one of the colleagues said she had to take another shot just to be eligible to fly. So this kind of choice is not here.
Thank you, Siraj. And then also like to David, a related question. David, I wondered with your new injection methods for vaccines and other medicines, can you already like say which vaccines, for instance, among the COVID vaccines might be suitable to that injection methods and which not? I mean, particularly I wondered like due to heating or putting pressure on the liquids. Can you already like in a way say, yeah, would it be a technology that can be used with COVID-19 vaccines, for instance?
Well, that is actually the question I start putting around in my network the moment that there were the first vaccines available. Because of course I had people asking me, hey, can we use it? And I said, well, first, when there's a vaccine, if I can have some vials to test it, then we can do the experiments and check. What I understand from some of these DNA, RNA vaccines is that they are formulated in a way that you have these sort of small vesicles or little droplets that we need to first check if in the process of injecting them, they don't break apart, or if they break, does it harm somehow the efficacy of the vaccine? But that I'm still waiting for those samples to arrive because, well, it's very hard to get. So the distribution chain, at least here in the Netherlands, is very tight. And then your question regarding the heating, there are two answers to that question. The first is that with the tests we have done with other medical liquids, we haven't really measured any changes in the chemical structure, but we would need to do some clinical trials to check what actually happens in living organisms. And the second is like the bottom line, or the let's say the last line of defense, is that we can also have a membrane in between the liquid that we are heating and the liquid that is supposed to be injected, and then you avoid any doubts or any concern.
Thank you, David. And then a further question to Luciana, and this is maybe continuing the comparison between COVID-19 and TB. And a few days ago, I've heard a talk on the World Health Summit in which basically the panelists emphasized how extremely lucky we also were in finding a COVID-19 vaccine quickly, and in a way that even with maybe increased efforts, we may not be as lucky with other diseases to find vaccines quickly. And TB and HIV were pointed out as areas where the research has been going on for a long time. So I wondered, maybe Luciana, again, what is your take on how likely it might be that an increased amount of funds could make TB vaccine available soon? And also in parallel, what are the other options we could focus on when the actual sort of feasibility of a technical breakthrough like a vaccine is so uncertain?
Okay, thank you, Stefan, for that interesting question. So in fact, it is quite clear that having a vaccine for TB is much more difficult than just, like, say, hitting one of the key molecules, or as it had happened with the SARS-CoV-2 virus, in the case of, for example, the spike molecule. So it is first important to mention that tuberculosis is a pathogen that coexisted with us for 1,000 years. Thus, this pathogen was able, in that long period of time, was able to develop many adaptations. It helped it to survive in our bodies for long periods of time. So in that sense, the bacterium is much more complex organism compared to the virus, to the SARS-CoV-2 virus. Just for you to have an idea, while Mycobacterium tuberculosis genes encode for approximately 4,000 genes, SARS-CoV-2 has from 10 to 14 open reading frames. So meaning that the diversity of the immune evasion mechanisms displayed by the bacteria are by far much more complex and complete than in the case of the SARS-CoV-2 virus. Also, as I say, the disease caused by Mycobacterium tuberculosis is chronic, meaning that it takes from months to years to cause symptoms. In the case of SARS-CoV-2, the incubation period of time is much shorter, from 5 days to 2 weeks. It has a really deep impact on the speed with which vaccine trials can be done. So it is not the same to wait 6 months for someone to manifest the infection than waiting for 2 years. So vaccine trials for TB are really slow, and were never profited by the option of combining, for example, clinical phases as happened in the case of COVID-19. So these factors, among others, as I previously mentioned, such as the fact of the low interest, low investment, can also explain why it is so difficult to control tuberculosis. And still, there are basic scientific questions that we still ignore in the case of TB, even when it has been studied for so many years. So the situation is much more complex in the case of TB, because it has been with us for a long period of time, so it got adapted. It displayed many immune evasion mechanisms, and also because the speed in which the clinical trials can be developed are completely different compared to SARS-CoV-2 virus. So I think that basically these are the factors that can explain why they were so, let's say, lucky. Also, there is another important factor. All the ICs and all the countries and all the scientific force were completely focused on solving the same problem, which was to have the vaccine for the SARS-CoV-2 virus. Of course, it is not the same for other infection diseases. So this is also another obvious reason that can justify why we were successful in getting the vaccine so fast in the case of SARS-CoV-2 virus and not, for example, in the case of the TB disease. So thank you for the question.
And we are close to the end of our session, so I would like to hand back over to Mai.
Thank you so much, Stefan. So now we are, before closing our session, I would like to ask our esteemed speakers to give us a very, very brief final message within less than 1 minute. So I'll start with Kate.
Yeah, so my main message is think about how you're communicating and who needs to receive that information. Pick the right language, pick the right mode, and make it as simple and easy to consume as possible.
Thank you. Marilee?
Yeah, so we must remember that our choices from a very high level to the level of the man in the street should be made in cognizance of those whose voices are sometimes not heard and who do not have a choice. So let's make sure that they are not fearful, but hopeful.
Thank you so much. So Dr. Suraj?
Okay, so to increase the coverage of the vaccine, seems to be a strong political will and diplomacy involved. However, the countries may be lagging behind in developing their own technology and human resource, especially in the vaccine research and development, also in the COVID-19 infectious disease research and development. So I think the countries should invest much in developing the human resource and the technology to increase the coverage as soon as possible. Over. Thank you.
Our inventor, Dr. David.
Well, my main message would be to encourage not only the scientific community, but governments, investors, big companies to try to strengthen the collaboration networks. Some are already there, but for different purposes. But now I think we should be able to solve this big problem without creating new ones, such as waste and all these freak accidents while injecting with conventional needles. Thank you.
So much. And last but certainly not least, our hero, Luciana.
Well, thank you. Well, I would like to highlight that, as in the case of the COVID-19, countries must step up their efforts to conduct assessments and develop action plans to transform their tuberculosis response into one that is equitable, rights-based, gender transformative, and people-centered. So I would say that we just emphasize that we urgently need more investment and greater political commitment if we are really committed to end tuberculosis and to avoid its co-epidemic with COVID-19. Thank you.
Thank you very much again for our speakers for sharing your expertise and for everyone who watched us today and attended the session. Thank you very much. And our message: get vaccinated, of course.